This is Dr. Babak Azizadeh. You are listening to the Smile Podcast, where I will be sharing with you my unique and holistic perspective on beauty, health, and wellness. Hello. Millions of people have surgery every year.
Or you could just get a boob job.
Using targeted Botox can be a miracle.
Smiling like that is a skill.
Your surgery has been successful. Hello, everybody, and welcome to the Zoom Smile Podcast. This is actually the first podcast we're doing on Zoom because of the recent coronavirus pandemic. We have obviously had to do some reformatting, and we welcome you guys to this Zoom podcast. And we're going to spend, obviously, this podcast, the Smile Podcast, is based on beauty, health, and wellness. I'm Dr. Babak Azizadeh, and our focus over the next few podcasts are going to be really on the coronavirus and how it's impacting various aspects of life. We're going to bring some world experts to discuss various aspects of the pandemic and the coronavirus. Today's special guest is Dr. Babak Larian. He is an ear, nose, throat, head and neck surgeon, and one of the best in the world, and lucky to have him not just as our guest today, but as my partner in our practice for the last 17 years and really 24 years almost, that we've been inseparable except for the last 4 or 5 weeks, which has been difficult. Although we talk all the time, we haven't really seen each other in person. So we're doing social distancing. It's very, very hard for us, but we're doing it. And hopefully we'll be back into our regular world. Welcome, and thanks for coming on today.
Thanks for having me.
All right, awesome. So this is like a very, I want to make this kind of interactive of finding out what you think obviously are important aspects of the coronavirus, but I'm going to go straight to your specialty, your ear, nose, throat specialty. And we know that the virus has impacted actually a lot of ENT surgeons that did not know why. And tell us why this actually has infected and impacted a lot of ear, nose, throat surgeons, especially in China and Italy, where it first really, took off.
Well, the reports from China did show that a lot of the doctors that were operating in the nose were mostly affected, more so than other specialties. And that was obviously very alarming. And then Italy followed suit with the same kind of statistics coming back. And actually, incidentally, there's going to be a webinar tomorrow that I'm going to be on with ENT doctors from England, from Italy, and here in the US, talking and sharing experiences and trying to figure out what the data is and kind of putting it together so we can figure out a path forward. But the thought is that, the reports show that the number of virus elements in a person's nose is the highest concentration seen with any kind of virus, any kind of respiratory virus. So there were reports that showed that the amount of viral elements in people's throats in the back of their nose was anywhere between 10 to 100 times more than the flu virus.
Oh, wow. Yeah.
Which is really, really amazing, because in having so many viral elements, if someone is coughing or sneezing or doing anything having to do with the mucosa or the mucus that your nose and mouth makes, that can transfer the virus in higher concentrations, of course. And so the whole issue of respiratory droplets come in. If you're doing anything that allows respiratory droplets to get, dispersed in the air, then whoever is in your environment can potentially inhale those in. It's kind of like a mist as you exhale or as you cough. Wow. You kind of create a mist of these droplets that have higher concentration of viruses than typical viruses we're used to. And if you're within a distance of that, if you're within 6 feet, which is an arbitrary number, it's not really a scientific number, it's just an estimation. If you are within a distance where you inhale this high concentration of virus in, you are now exposed and you can potentially have these viruses infect your body and go forward. So, when we do surgery on the respiratory system, on the nose, on the throat, we're putting instruments in and bringing it out. That process of putting the instrument in and withdrawing it out brings out all sorts of respiratory droplets with, and that's the exposure that doctors have.
And we call that
kind of
aerosol generating procedures. And that kind of hangs around for how long, like in that environment?
Well, it's hard to know how the time frame for how long it's going to be, but it all depends on how much airflow you have in that environment. So, at the hospital, at our hospital, they calculated based on the negative airflow that they have in the operating rooms, that every 5 minutes, the entire air in the room is removed and replaced by new air. So if it's in the air, within 5 minutes, that's removed. But that's a controlled environment where there's negative pressure with the air conditioning suctioning, the ventilation system suctioning the air out of the room, right? How it's going to be elsewhere when you're sitting outside like me in my backyard and there's wind and passing by and pushing things away. That number is different than when you're in a supermarket where there's not as much of an airflow, right? Big, huge Costco type warehouse thing where you're not going to have as much airflow going on. So, the numbers are different for that.
Now, one of the areas that we know there are a lot of false negative tests in the coronavirus swab test. What do you,
Yes.
and that's something that, they put a little brush or soft brush through the nose to get some viral elements and to see if that there's coronavirus. Why do you think the percentages of false negative, meaning the test coming back, the results being negative, but the person actually having coronavirus wasn't detected? Why do you think that happens?
Right. Well, the highest concentration of viral elements is all the way back in the nose. So if you look at me in profile, my nasal cavity extends this far, all the way back to just in front of the ear, right? So when they put the swab in, they need to go all the way back to here to swab the back of the nose in order to be able to get an adequate specimen. So, it's not a very comfortable thing. So if you are quickly trying to put that in and the person moves their head, you may not reach the end point where you need to be to get an adequate sample. Add to that to the complexity that if you have a deviated septum, which means this little thing in the middle of your nose extend all the way back, if that's bent and you try to get the swab in, it may not allow you to get in there. So you may catch at an earlier point. And if the person who's doing the swabbing doesn't have as much experience with it, may feel like, okay, well, I reached the end of the nose, that this must be it. And they may get a sample from an area that's not exactly the back of the nose. And so there's many reasons for failure in that regard. Other reasons for failures is that some of the tests that have come out in the public are not validated tests. So they may not be actually good tests to show results appropriately, So there's too many factors here.
That's what I worry about. I think one of the things as physicians, we're constantly getting, oh, there's a new kit, there's this, there's that. But because things are coming out so fast, I think there are a lot of tests, whether it's the blood tests for the antibodies or the swab tests that I think are just not validated. They're not FDA approved. They're being rushed. Their testing is not being done. Can you tell us a little bit about the difference between like the testing by blood or versus the swab test? What are they looking for? What's the difference? And maybe a little bit of information about, people are going to hear IgG, IgM, and so forth.
Absolutely. Those are very important questions. So the swab test in the nose is actually getting a sample of mucus that has virus in it, right? And the test is actually looking for the virus itself, for the genetic code of the virus, or the RNA element inside the virus, which is exactly holding all the code, which tells the virus how to get inside the cell, how to duplicate and replicate itself, and how to make new virus and then kill the cell and get out of the cell, right? All that information is hidden in that. So we look for those elements when we do a swab test to see if that RNA sequence exactly in the sequence we're looking for exists, right? Or the hot spots on it exist. When you're doing a blood test for the IgG or IgM, you're looking for your immune system's response to that, right? So when you initially get this infection, your immune system has not had a chance to mount a response, okay? So if you were to do the blood test right on the day that you got this infection, that blood test would be negative because your body hasn't had an opportunity to form antibodies to the virus. So just to go back to that, when we get the flu virus or common cold virus, when it gets inside our body and gets into our bloodstream, our immune system is alerted to it, right? And we have these white blood cells going and searching to see what's going on. Our white blood cells are constantly in the process of surveillance of our whole body, right? Big brother is essentially our immune system. It's big brother in there looking at everything, feeling everything to see if there's something that's going awry. And so when they see these viral elements that clearly don't have your genetic character, then they know that this is something foreign, and then they start attacking it. So the initial stages of it are white blood cells directly attacking things that they see as foreign, right? But after a little bit of time, there's another guest.
Hi.
After a little bit of time, so this is not a background.
This is not a background. It's real.
After a little bit of time, your immune system starts recognizing the commonality that all these elements have the same things on their surface, right? So they make antibodies directed towards those common elements, right? So that then when those antibodies go and attach to the surface of the virus, that guides in other immune cells to attack, right? And more directed. The first set of cells are just attacking whatever they think is foreign. The second set are targeted. It's like drones, like target ready. This is the specific thing. The drones are going in, attacking that specific thing. Now, those antibodies come in two forms. The initial form of an antibody is an IgM, right? That's an acute antibody. When you have an acute attack, IgM rises, right? Directly attaches to it, right? Immediately, and the attack goes on. The second set of antibodies is IgG. IgG stays in your body, right? It's constantly circulating, waiting for another virus to get in to immediately attack it. So when you do the blood test, you check both the IgM and the IgG. If you do the test and it shows that your IgM levels are high, that means you just immediately are either in the middle of the attack or just recovering from the attack, right? Mostly meaning that you're probably in the middle of it because your immune system is fully attacking it. But if you test and your IgM is normal or low and your IgG is high, it tells you that you previously had this infection. Currently, you are not infected, but you have some degree of immunity. What degree of immunity we have to that is uncertain at this point.
Yeah, we quite don't know if you can carry that immunity card, but that may be an important role, right, in the future as we want to get back into normalcy.
Absolutely.
Now, one of the questions that we often get asked is, when someone has coronavirus and they actually sneeze, right? These particulates come out of their nose. What is the chance of me, if I'm close to that person, getting it if they have a mask on or if they don't have a mask on? And vice versa, also for myself. Right.
Very good question. But obviously, if they don't have a mask on, the droplets are going all over the air, so the chances are significantly more that someone can get it. Not only directly from breathing it in, but because when it settles on the furniture, on the things that are around them, right? So again, if you're out in a market, they sneeze and it settles on the stuff and you're picking up the oranges or whatever you're getting, and if you're not wearing a glove and you get it, and just like me, you've noticed me during this conversation, I've touched my face several times, right? Well, yeah, which naturally we end up doing. You know, we have all sorts of sensors on our face. We get itchy on our noses and things and beards and whatever all the time. So we touch it without realizing that we're doing these things, you know? Or if you have hair, you play with your hair all the time, you know? So if you have gloves on, right, you're less likely to be touching your face. It's just a natural thing because it doesn't feel good, right? And so if you are protected yourself, if you're wearing a mask, then if they sneeze, it's less likely that those droplets will get through from the sides of the mask and get in, especially if you have a good mask that has tight fitting, right? But so it's all statistics. You decrease the probability of this virus being able to get through if you're wearing a mask. If the other person is wearing a mask, less likely that through the side some of those droplets will come out. Some will come out because they're pushing as they sneeze, right? And the mask comes forward a little bit, so there'll be some that'll come out, but less many viruses are going to come out. And if you're wearing gloves, right, you're less likely to touch your face. You can still touch your face, but you're less likely. So all these protections have inherent meaning in them.
And what's the difference between someone wearing a N95 mask and a regular surgical mask?
The regular surgical masks actually have a little bit more space on the sides, right? Because when you're wearing a regular surgical mask, you don't want to be directly breathing on the wound that's in front of you, right? And getting any of your droplets as you breathe onto the wound. But from the sides, that's relatively okay because it's not coming onto the field. So the sides are a little bit open, right? The M95s are not open at all. They are tight-fitting masks. These are the types of masks that after surgery, when you take it off, you have exactly a line around your face where they've been sitting on tightly. So when you wear those masks, all the air that's going in and out is going through the fabric of the mask rather than from the sides. So those are much better protection. And in the hospital wards where doctors go to see patients who have the coronavirus, the SARS coronavirus 2, they all wear these kinds of protective masks because they don't want to exchange any of those droplets.
Now, you're a ear, nose, throat, head and neck surgeon, and obviously your practice has been impacted by both city ordinances, by society guidelines, by the state, because they're allowing you not to do elective cases. You have done some cases. Can you tell us a little bit about why you had to do those cases, what the situation was? Because I think a lot of what's going to happen, and we're going to see over the next few months, is delay of care can also impact people's lives.
Absolutely.
So where do you see, tell us a little bit about what cases you have had to do and how you see kind of getting back to normal and why we need to get back to normal quickly.
Well, the last case that I did was close to a week and a half ago. And that was a patient who had a cancer. And that cancer had spread to the lymph nodes in the neck, so obviously it was progressing. And waiting a month and a half to treat this person was just not feasible because by then the cancer could have spread to all parts of the body and made this person not be curable, right? And so that was something that I had to get done. These are the non-elective cases. It has to be done, right? Another surgery that I did probably a week and a half prior to that, or 2 weeks prior to that, was on someone who had breathing issues because they have scarring in their breathing tube, and every few months this scarring would narrow down the caliber of the breathing tube. So they essentially breathe through a straw. And this is a patient that I've had for years and years and have to every 3 to 4 months take him to the operating room to dilate and stretch their breathing tube. And so this was time, and we had tried to kind of try to delay it, but she got to the point where she was having a hard time breathing, and just taking a few steps, she was running short of breath. So we had no choice. Fortunately, I was able to avoid taking her to the hospital. We were able to do it at a surgery center, so less exposure, and a more controlled environments. Not, don't have an emergency room or the traffic. There's no foot traffic or anything like that. So, and that patient was, if I had not done it, she would have ended up in the hospital not breathing and intubated and
much
so
worse situation, and potentially impacted if she gets the coronavirus, right? Because that's how the infection kind of goes down towards the lungs.
Absolutely. Now, when we do the surgery, we take amazing precautions. Everybody is obviously wearing the appropriate protective gear, so there's no breathing from the side of your mask or anything like that. When the doctors are putting the breathing tube in at the beginning of the surgery, everybody else leaves the room except the anesthesiologist, which is fully geared up and in the appropriate facial gear, covering the eyes and the face, mouth, everything else. And then for 15 minutes after this breathing tube is placed in, no one comes in the room, right? Just so that the ventilation system can take everything that potentially occurred during that process out of the room so nobody else gets exposed. And then the surgery begins. You also don't want to open the wound or do anything else in that time period. In any case, both surgeries went well. Those patients have all done very well since that time. So, being judicious at this time is that's what you got to do. You got to be smart and deliberate about what you're going to do, because you're trying to not harm someone in the process of helping them. Now, in terms of elective cases to start again, that's a harder decision. I think what we don't know at this point is what percentage of the population is infected. That data is not in, so we don't know what percentage of the population has immunity. We don't know that either, right? What does that immunity mean? Does that mean that if you have that immunity, you're not going to get that infection again? Is that immunity a strong immunity or a weak immunity? Don't know that either, right? And so if the city ordinance is changed so that we can start seeing patients, we're going to have to take amazing precautions with assumptions that we don't have adequate information, and any person could be potentially a carrier and potentially someone who could spread the virus still to patients. And so we have to be judicious in terms of who we're going to see in our practices, not the smaller surgeries, the less important things we're going to have to leave for later dates when more information comes in.
Why do you think, and this is kind of what I'm grappling with, why do you think that, we need to kind of really think about, delay of care, and it may be that there's different specialties have different issues, and it may be that, okay, you know what, you need a colonoscopy, fine, you don't need to do it today, but what can be the danger of maybe not doing a whole patient population of colonoscopies and delaying like patients who could potentially have colon cancer that we're not treating? We know, like, for example, colonoscopy saves lives. It's the number one preventative, probably, cancer because of, colonoscopies. What do you think? I mean, how are we going to balance that with what's happening with coronavirus and the hospital systems and so forth?
And that's a very difficult question to answer, actually, because, in the process of trying to prevent, we're also seeing a lot of, so when you do colonoscopies, fortunately, a great majority of people who have colonoscopies don't have cancer. It's that minority whose lives we're saving. But it's that same minority that right now is compromised because they don't know themselves there's something wrong. They don't know that the cancer is growing. Now, for certain things, that may not be as important. Like most of thyroid cancers are slow-growing cancers. So if the diagnosis and treatment is delayed by 2 months, 3 months, 6 months even, probably the course for that patient is not going to change. The cure rate is not going to change. But for, pancreatic cancer, which is an aggressive cancer, melanoma, which is very aggressive, for those cancers, they're not as forgiving. They don't give us the luxury of time. They really need to be addressed immediately. And so, I think there's going to be a second wave of people who will suffer the consequences of this time period. And so for us doctors, we have to really be smart about, when we have a degree of suspicion, we got to try to bring the patients in and get them into an environment that's safe, that we can do the procedures, take the appropriate precautions, and go on, And I think every specialty has to go through the process of deliberating on that equation.
Yeah, and that's why I think for our listeners and viewers, I would say that if there are things that concern you, the consequences of those may be more than the consequences of a coronavirus infection. So make sure you're not delaying. If you have chest pain, go to the doctor, or go to the ER. If you have a laceration, big laceration, try to find someone maybe that could treat you outside of the ER. If you have a suspicious mole, go see your dermatologist or contact them or do a video evaluation so that they can make sure, like you said, it's not melanoma. If you're in a high risk group of colon cancer, make sure you're not delaying your colonoscopy. So we have to be very educated because, like you said, I like that second wave. There's going to be a second wave of issues as a result of this coronavirus that we need to be aware of, and we need you as the listener to be aware of.
I think a lot of times when you communicate with your doctor, they can kind of stratify your risks. They can ask you questions and say, okay, based on the symptoms that you have and how long you've had it and your family history, you're at a higher risk. You should do a colonoscopy, let's just say. And you're at a much lower risk. I think delaying it a month is not going to be detrimental, With dermatologists, my brother's a dermatologist. He does these Zoom consults every day. And one day a week he goes in and does biopsies, right? So he's categorized his practice, right? On that one day, he has one person with him. So there's not a lot of people in the office that can increase risk. A few patients are coming in only at a time. So, doctors can organize themselves in a way to be able to still really help you out and prevent disasters.
Now, you've modified your practice a little bit, and now you've been doing video evaluations and inquiries for years, because
Absolutely.
so many of your patients that are coming in for parathyroid or thyroid or parotid, they're coming from all over the world. How have you modified your practice and over the last few weeks?
Exactly the same way. Now I do video consults. Most of the less acute issues are really not, calling or making appointments, which is good and bad, because a lot of things that may be allergies and, people think they're nasal allergies, if not treated well, turn into infections, right?
Yeah.
And could be preventable, right? So, but a lot of those people are not calling in and only calling in when it has already turned into infections.
Yeah.
Which is why I try to always educate my patients so they can self-treat appropriately and know when they should be calling me to help along. But I think when in doubt, get in touch with your doctors. Most doctors are making themselves available through these mediums to talk to patients, and so there is still access to healthcare, be it video or just a phone call, and then your doctor can direct you as to the next appropriate step.
Yeah. Every major event has some long-term consequences and changes that come about. What do you see as a major shift or change in healthcare delivery and healthcare systems as a result of this pandemic?
Well, I think this pandemic has shown some of the weaknesses that our system actually inherently has, and so we have to address those issues first and foremost on a population level, right? And the disparities between different populations being affected by it. These are really meaningful and important things that we as a society have to address. But I think on a more practical level, on a day-to-day basis for me and my own patients, I think we all have to take extra precautions when we meet. The warmth and friendliness of our relationship will change. When the patients come in and I shake hands, and I used to hug a lot of the patients and so on. That unfortunately is going to change and will change for a period of time, if not permanently. Hard to know how that's going to be. But we also have to figure out how to still create warmth and connection with our patients. And that's really important, because I feel like that's a real important part of being someone's physician.
And not
being
robotic.
Someone's healer. Right. And we can't be robotic and just try to sit 6 feet away from every patient and not touch them, wear a mask and gloves and not touch them, be afraid of them, which is something that I used to see back in the early days of HIV. Doctors who still had no information would be always sitting back and, we saw that. It was crazy. And at the time in the operating room, some of the surgeons would be standing on the other side of the room and not wanting to touch a patient who was HIV positive or potentially positive, just because of lack of information, bias, misinformation, all sorts of things.
Yeah.
But sorry, I had a phone call. In any case, so I think we need to figure out a new paradigm which brings safety, but also warmth and care to the relationship.
Yeah, I agree. I think what I hope won't happen is the warmth and the positive energy that patients need to be able to get, great outcome. And one thing I have to say I love about the changes that are happening is seeing like people in their family setting, like I'm seeing This
We
is
have
the
another
best
guest.
part. This is the best part. We have a special guest. But yeah, the warmth and energy, I hope, doesn't change, because that was already changing. If you see the younger generation with
Yes.
their connectivity being purely through text, not interacting as much.
Right.
But I also
Yes.
hope that this will, like, maybe on the other hand, make a lot of people want more interpersonal interactions. And also, I think our communication, telemedicine is going to really, really become a much, much more important medium. And, hopefully that actually will help people. A lot of
Yeah.
times I see like 2 hours people driving in and driving home for a 5-minute checkup that can be done on video. It can save a lot of, hassle, risk, and so forth. And
Absolutely.
those are
No,
wonderful.
I think the paradigm changes, and the healthcare system has to catch up to that.
Yeah.
We live lives that are very remote. People drive, half an hour to an hour every day to get to work and to come back, and then to cut out of that and then go to a doctor's office is an impracticality that may not work out for most people, which delays care. But if they can get in the middle of their day, they can make an appointment with a doctor and talk to them via video like this, and then figure out the gravity of their situation so they can dedicate the appropriate time. I mean, that's an important thing that allows people to have more of an opportunity and access to healthcare.
Well, I want to thank you. Dr. Larian is a very, very busy man. Seriously, even during these times, he's the chief of the ENT division at Cedars-Sinai. He's very involved in all the things that are going there, and with his life. We appreciate you. I miss you. I can't wait to hug you. I will hug you regardless.
Absolutely.
Once social distancing is over, and we will operate again together. And
soon, hopefully.
The experience, no one has, I think, a better job in the world than me, because I get to hang out with one of the best people in the world all the time and be able to operate with, brainstorm with, cry on their shoulders. So I'm very, very lucky. And it's such a pleasure working with you. And you're just, I think the way you think about things in life and healthcare, and even, your coronavirus philosophy, all of it is just like really wise. So I appreciate your time and look forward to seeing you.
Thanks, Babak. I really appreciate it.
Have a good rest of your day, okay?
Likewise.
All right. Bye.